a shortage of skilled healthcare workers. These are some of the primary barriers that prevent many Nigerian women from receiving the care they need during pregnancy and childbirth. We have a distinguished panel of experts with us today to discuss the crucial topic, and we'll be identifying maternal health challenges and opportunities that exist in Nigeria, building consensus on the urgency for innovation in maternal health as a key lever for human capital development, demonstrating to decision makers the benefits of improved maternal health, and mobilizing support for primary healthcare revitalization through the Adopt a Healthcare Facility program. Our panelists include Dr. Amina Mohammed Baloni, the Honorable Commissioner for Health for Kaduna State. She's currently serving, like I mentioned, as the Honorable Commissioner for Health in Kaduna State. She graduated with an MBBS in 1991 from the Ahmadu Bello University, Zaria, and she holds a master's in public health from the University of Liverpool with over 20 years of practice, first as a clinician and then as a public health professional. Dr. Baloni has worked with UNICEF Kaduna Field Office as a health specialist responsible for providing technical assistance to government and other counterparts on health programs, including maternal health and child health interventions. Welcome, Dr. Baloni. The next panelist we have is Dr. Jide Idris. Dr. Jide Idris is a former Commissioner of Health for Lagos State, where he was responsible for healthcare planning, health policy formulation, as well as supervising health service delivery in the state. Dr. Idris attended King's College, Lagos, Nigeria, is a graduate of the College of Medicine of the University of Lagos, Nigeria, and holds a Master's of Public Health from Yale University. Under his leadership as the Permanent Secretary for 3 years, Lagos State health system saw significant upgrades through a comprehensive health sector reform agenda. We're looking forward to receiving your insights. Welcome, Dr. Idris.
Thank you.
Our third panelist is Mrs. Uzoma Ezeoke, the Executive Director, yes, sir, the Executive Director in Emzor Pharmaceuticals. Under her leadership, Mrs. Ezeoke is responsible for a diverse responsibilities that even extend beyond Emzor's legacy in pharmaceutical manufacturing, affording her the opportunity to work in emerging areas of the group's business. Mrs. Uzoma is energized by artistic expression and is particularly drawn to spoken word and written word. And we're looking forward to the insights that she can share coming from another angle and another approach. Welcome, Mrs. Ezeoke.
Thank you very much.
Finally, thank you. Last and not the least, we have Ms. Iyadunni Olubode, who is the Nigerian Director for MSD for Mothers. Ms. Olubode has over 17 years of experience in the private and developmental sectors of Nigeria. Mrs. Iyadunni has been responsible for the Nigeria portfolio for MSD for Mothers since 2018. In this role, she oversees the development and implementation of several capacity development programs in collaboration with private and public sector stakeholders and developmental partners. Ms. Iyadunni earned a BSc in economics from the University of Lagos, and she holds a master's degree in economics from the University of Surrey, Guildford. Welcome, Ms. Olubode. And to introduce our moderator for this panel, our very own MD and CEO of the Private Sector Health Alliance of Nigeria, Dr. Tinuola Akimbolagbe, is an experienced, highly collaborative team player with relevant board-level experience and a demonstrable track record in the health and allied sectors. Dr. Akimbolagbe holds a degree in medicine and surgery from the College of Medicine, University of Lagos, and a postgraduate diploma and master's in public health from the London School of Hygiene and Tropical Medicine, University of London. Dr. Akimbolagbe is actively involved in mentoring students and young professionals and works with several charities and nonprofits to raise funds for community health services. Thank you so much, ladies and gentlemen. We look forward to listening to the insights that will be shared from our panelists. Welcome once again. Thank you.
Thank you so much, Otta, for a lovely job. Very well done. The good thing about being the host is I get to write my own brief, so I can be as flattering as I want. It's great to have our panelists on board. I just realized something. I mean, we could use the excuse of the International Women's Day being March, but I realized we have a preponderance of women on the panel. So I know Dr. Idris is more than able to hold his own and represent the male gender, but we will do a better job of gender equity in future. So I welcome you all. I thank our audience and our distinguished panelists for taking time out of their busy day to be here to discuss such an important topic. We've been very deliberate about our choice of panelists because we wanted someone to speak from the public sector point of view, from the private sector point of view, and also from the civil society point of view. Our distinguished panelists, I've also found a number of them are fellow alumni. So Dr. Baloni, I realized that you're an alumni of Queen's College, which I'm one. Iyadunni, I realize you're an alumni of University of Lagos, of which I'm one. And Dr. Idris, an alumni of great Idi Arabites, College of Medicine. Ms. Ezeoke, I know that we're not fellow alumni, but I do know we have
I
lots
went
of
to Queen's College. I was waving when I heard that.
Really?
Pass on the torch over here, please. Thank you.
So it's wonderful to be alumni of such institutions, and I really do know that we're passionate about moving health forward in Nigeria. So as I said, my name is Tinola Akimbolagbe, and I'm hoping to be able to move this discussion forward. For the next 1.5 hours, we will have an interactive panel. We will have our panelists speak a little bit. We'll take some questions for them, and then we'll take a question and answer section from the audience. Our topic for today is improving maternal health through innovative partnerships, opportunities, and challenges. I'm not going to go over what Otta has already done, but the point of this is to look at how innovative partnerships between different stakeholders can actually help to move maternal and healthcare services forward in Nigeria. So despite the potential benefits demonstrated by these partnerships, there's still a number of challenges in Nigeria because we have a lack of coordination amongst the stakeholders. So sometimes we have duplication of efforts and inefficiencies. The lack of coordination can result in duplication of efforts and inefficient use of resources and limited impact on the maternal health outcomes that we desire to change. Additionally, inadequate funding and poor planning for sustainability are significant challenges that partnerships face in Nigeria. So I'm going to go to the first question that I have on the list. And this is a question that I'm going to address to everybody, but we will start with Dr. Baloni. In your current roles, or in your current or previous roles that you've had, what are the specific roles or what are the things that you in your specific role or your organization is doing towards the betterment of maternal health care and maternal health services in Nigeria? I will start with Dr. Baloni and then go to Dr. Idris. Over to you, madam.
Okay, thank you very much. Thank you. I'm honored to be on this panel and to have so many QC girls on the panel as well. Talking about maternal and child health, of course, a corollary of maternal health. You can't make sure the mother is well without thinking about her offspring as well. The state has a number of initiatives that we've taken. We recognize that we have poor indices, especially compared to the national average. By 2017, we had about 1,000 deaths per 100,000 live births of maternal mortality. And so One of the things that was put in place was free maternal and child health services. And the free maternal services comes in the form of antenatal care and delivery, which is free. We've also revised our policy, the maternal and child health policy, to look at what are the current trends, what are the best practices, to see that this is implemented wholeheartedly. We have over 1,000 primary healthcare facilities, and recognizing that this is the first level of care for most of the women, and most of the women in the rural areas, we've embarked on upgrades and recruitment of staff, or upgrading their skills to be sure to be able to take deliveries at that point. We have revamped our communication strategy. As you know, some of these things are learned behaviors, some of them are cultural behaviors around going to deliver in the facility. And we've tried to do a lot of work with champions and community people to encourage women to come for at least 4 visits for antenatal care. And then the free maternal services kicks in. So whereas before it would be about, oh, it's too expensive, we've taken that away by increasing financial access to that. We've also tried to work on quality of care to make sure that when there's a standardized protocol that is followed at that level, when a woman comes in pregnant, what are the things that she should have done? Basic urinalysis, blood pressure checks, make sure she gets the immunizations, the tetanus that she needs, and then evaluate her at least 2 or 3 times before she delivers. Now, we haven't been so successful. Our antenatal care has gone up to about 70%, but we haven't really been so successful. About half of these people don't turn up for deliveries at the facilities. And so this is where we have a little bit of a weakness, which we're working on. But we do recognize that some of them actually go to private providers. And because we don't have a comprehensive database of that, we may have a little bit more going there. So our stillbirth delivery is still around 32%, which is not so good. So these are some of the things that we're trying to work at in Kaduna State to improve our indices. Our recent mix has shown that we have actually made significant progress in that and in neonatal care. And you know, neonatal care also is to do with stillbirth attendance. And we've improved from about 60 to about 42. We're awaiting the results of the NDHS to see the improvements that we've made in maternal mortality. But these are some of the things that we're working. And of course, partnerships with everybody that is in that space, and working to make sure that everybody aligns to the state goals and to the state's priorities. And so that we leverage resources and prevent the wastage that usually happens when people work in silence. Thank you.
Great, thank you so much. I do think that achieving 70% antenatal care is something to be celebrated. I mean, even though you may not have everybody show up for delivery, some states have nowhere near that percentage of people registering for antenatal care in the first instance. And some of the other initiatives that you've mentioned are quite significant. Over to you, sir. In 1 minute, can you give us an overview of what your work entails in relation to maternal health? A lot of us know about it, but for the benefit of the larger audience.
Thank you very much for inviting me here. I'll just go straight to the point, and I'm going to use as an example what we did under BRF's time when I was in office. We actually created a maternal mortality reduction program during his. Can you hear me?
We can hear you, sir. Yeah. Perfectly.
We actually established a maternal mortality reduction program during his tenure. And I want to say that it was quite comprehensive. And initially what we did was to establish a committee involving many stakeholders, both from the public and private sectors, including donor agencies. And I guess in the context of partnership. And the first thing we did was to do a situation analysis to find out what a maternal mortality ratio is, was in Lagos State. And we considered a team headed by private organization, CAUP, Coalition for CAUP, I can't remember, unwanted pregnancies, private sector-led initiative, who conducted that exercise using the sisterhood method. And based on that, we got a figure of 555 per 100,000 for Lagos State. We also did a gap analysis, what is analysis in terms of the different resources we had at the state level. And this was also just to give us which area to follow. And that committee now established the programs and plans that we want to follow. And those programs covered so many areas in terms of leadership and governance. We thought of legislation, we thought of regulations, we even thought of quality of care. We looked at infrastructure, what was available, especially at primary healthcare level, what we had in place and what we needed to do. We looked at financing, and luckily around the same time too, we're thinking of a community-based health insurance scheme things, which we needed to link up with. We addressed the issue of training, especially human resource for health. What we had, especially as one of those interventions, has to do with the use of trained birth attendants at the various facilities. And of course, we involved the private sector to a lot of things we were doing, because most of them were part and parcel of that committee. An example was that we partnered with SOGON, Society for Gynecology and Obstetrics of Nigeria. And with SOGON, they came up with what we call the maternal death review, and then maternal perinatal surveillance review for Lagos State. And these were various efforts we had to do just to address the issue of maternal mortality. And of course, throughout, we were considering data issues, databases, just to monitor how far we've gone. And a major aspect of that, again, was involving the community. And there was a massive advocacy at the community level, local government level. We went from local government to local government, advocating for all these educated women with respect to causes of maternal mortality and morbidity, what they needed to do, which facilities should go to, and what commodities they had. So like my colleague in Kaduna State said, part of that insurance was we implemented a free health scheme, and especially trying to link up maternal mortality issues with a health insurance scheme thing. Maybe I should stop there. So now, thank you.
Thank you so much, sir. I do agree that Lagos has often been at the forefront. Lagos leads and the rest of the states followed. And a lot of things that were done when you were the Commissioner of Health led the way for evidence-based decision-making. You worked a lot using data, and I'm thankful you were able to entrench that in the Ministry of Health in Lagos State, and that is still what they work with now. I'll address the same question to Uzoma. For the benefit of the audience, can you just give us in 1 minute an overview of what your work entails in relation to maternal health?
Okay, thank you for that. Well, Emzor is a local manufacturer. We also have a subsidiary that's active in the medical equipment and consumable space. So I'll start with our core base, which is manufacturing. We have a very strong focus on a maternal and child health portfolio. One of the leading causes of mortality in pregnancy is malaria. Figures vary, but roughly 11%. There is one recommended product for the prevention of malaria in pregnancy, and this ties quite a lot into what Dr. Baloni was saying. You should have a minimum of 3 preventive treatment doses, and preferably up to 5. So if the women aren't coming, it's a little bit more difficult to get that across. So this is a product that we've manufactured for close to 2 decades in the country, and have taken a step further. A lot of the initiatives around managing outcomes in pregnancy are related to the NGO space. And these products are usually always imported. And that's done under the auspices of wanting to ensure the quality standard. So we embarked on a WHO pre-qualification program, which would give our products the highest ranking globally. So we just had our inspection earlier this year, because this is a really important step, domesticating manufacturing, ensuring access, and eliminating any questions about the quality of what is produced here. Because we see with these programs, they're not immune to the supply chain. At times, you're told you can't supply your product because it's not, ranked yet. But when there's a breach in supply, you may donate. So we said, let's sort this out completely. There are other areas that contribute to maternal mortality. One is postpartum bleeding. And the key product that's used for that is rather sensitive to manufacture. So we embarked on a tech transfer agreement to enable us to do that at our new plant here in Lagos. So now we are the only ones making this product in country, and really, on the west coast of Africa as well. So we know that access to medicines plays a strong role. And on the other end, we're interested in PPP projects. Screening, really important. And we know that, as was mentioned, a lot of women seek care in the private sector. So we have payment plans, for physicians. And sometimes that's executed through a fee-for-service agreement. We'll bring the equipment in. Of course, you have to put somebody there to ensure monies are duly collected. And the institution pays off, the equipment over some agreed period of time, but it allows people to get started. And we've done the same in our government-run tertiary institutions as well. So there's quite a lot. And of course, newer products that are in development. We've got products for anemia also launched. That's a contributor. But with IV product, with an IV product line that's under construction, that would allow us to do some of the injectables that are really critical for lowering maternal mortality numbers.
Fantastic. Thank you so much for that. Emzor is a household name. Lots of pharmaceutical companies that started at the same time as Emzor are no longer in existence. So even having been an operation in Nigeria for over 30 years is a feat in itself. And I do think you should be commended. And your mom, who I had the pleasure of meeting on a number of occasions, for that legacy and for you for sustaining the innovation. In the area of malaria, in the area of uterotonics, which we will talk a bit more about, which is a major solution to postpartum hemorrhage, and some of the PPPs and the innovative steps that you're taking. It's on record that more than 90% of medication used across Nigeria, not just for maternal health, but for all conditions, are imported. So anybody who's able to manufacture within country and provide at an affordable rate should be supported. So thank you for that. So I've saved the best for last with my very own Iyadunni. So I'm going to ask you the same question. In 1 minute, can you give us an overview of what your work entails in relation to maternal health in Nigeria? Thank you.
Sure. Thank you, Tinu, for having me. And hello to all our distinguished panelists. I've met all of you in one capacity or another, maybe not in person. So MSD for Mothers is a global initiative. It's a global initiative of the global pharma company, MSD, known as Merck in the US and Canada. And the goal for MSD for Mothers, the broad vision, is to help create a world where no woman has to die giving life. We believe that in 2023, most maternal deaths, evidence does show that most maternal deaths are preventable. And so how do we change the norm? How do we begin to spread the philosophy that not all women have to die? Because in our culture, there's a preponderance of, it's the will of God. And one way that we're approaching it, how we approach this, is as a private sector organization, we aligned with the Sustainable Development Goals around maternal health care. And that SDG, I think it's SDG 3.1, is targeting an MMR, a global MMR of not more than 70 deaths per 100,000 live births. As a country, we're some distance from that. We recognize that to be able to achieve this, we need a collaborative approach. You pointed to people working in silos. We need everybody all hands on deck. I like the way the Lancet Commission says it. We need a whole government and whole society approach, including private sector. And as a private sector organization, we put our money where our mouth is and said, we're bringing resources, not just financial resources, but also technical expertise to address this stubborn problem of maternal health. In Nigeria, as with the rest of the world, universal health coverage is, the hot button topic for a lot of countries, because we recognize the health inequities, and it's important that everybody has access to quality health care, quality maternal care. It's a fundamental right. And so we're saying, how do we bring to bear the private sector expertise to address this problem? Universal health care cannot be delivered in Nigeria by only the public sector. We can leverage the reach of private facilities. But if we're leveraging the reach of private facilities, how do we ensure that they're delivering quality? Because we know a lot of those private facilities do not deliver quality care. And so quality improvement, quality accreditation is one of the key thrusts. We believe that it's important to train these private providers and put systems in place to ensure that they deliver quality, because you don't want to incorporate into a health system providers who are not delivering quality. We also believe that one of the things that private sector offers is innovation, the innovative capacity, the expertise the capacity to do things efficiently. And that's another strength that the private sector can be leaned on to address this challenge. A third approach is really the community approach that Dr. Baloni referred to in her prior conversation. We recognize that for us to have any lasting impact, we need to put the patient at the center. And in this case, if we're talking about MNCH, that patient is the woman and the children. We need to understand how they receive care, their perception and their experiences, so that we're understanding the problem. Dr. Idris also talked about MPC. Now we call it MPC DSR, maternal and perinatal death, child death surveillance, understanding why the women are dying, so that we can also fashion solutions that meet the women at the point where the need is. And then we can carry women along in that value chain where they're assessing, they're contributing, their voice is heard when we're assessing the change. Also the community stakeholders. We've seen how community stakeholders, from our experiences in Cross River states and now in Kaduna State, how engaging the community stakeholders is critical, not just the religious leaders, husbands, mothers, even the traditional birth attendants. We're not saying ask them to have children, but communicate to them so that they understand the danger signs. Put them in touch with the facilities so that when the women are with them and are clearly requiring care, they're not shying away, they don't feel reticent or that they will be blamed, but they can connect. So a lot of the work that we do in Nigeria is really around those three approaches. How do you institute quality care? How do you take innovation from the private sector and expertise from the private sector and leverage that for a unified and integrated health system? And how do we bring the community into this conversation? Because sustainability will depend on community buy-in and engagement.
Thank you so much. The work that MSD for Mothers does in Nigeria intersects with a bit of what PSHAN does, the focus on the private sector and private capacity to intervene in healthcare. I do agree with you that the patient should be at the center, must be at the center. And we need to exploit some of the things that the private sector is known for: innovation, efficiency, and accountability. So thank you for that. Before we let the full cat out of the bag, we normally would have done a poll. So we'd like to do a poll right now. Please, panelists, don't worry, you won't skew the results. Can we have the poll on the screen for the audience? We have 3 questions on the poll. So number 1, what is the leading cause of maternal death worldwide? Note, the question is not in Nigeria. What is the leading cause of maternal death worldwide? Number 1, option A, unsafe abortion. Option B, high blood pressure during pregnancy, preeclampsia and related conditions. Number 3, postpartum hemorrhage, severe bleeding after delivery. And number 4, lack of child spacing. So can everybody vote on that? So question number 2, okay, we're taking all 3 questions at once. The biggest challenge associated with maternal and child health services in Nigeria. Number 1, poor health infrastructure. Number 2, distance to health services. Number 3, financial challenge. Number 4, lack of awareness. Please vote on that. And the last question, what is the most critical step, in your view, that is required to improve maternal and child health services in Nigeria? So for this question, you get one choice. More financial investment in healthcare, that's option A. Improve the quality of healthcare workers, option B. Increase the number of health facilities available, option C. And increase the knowledge level amongst women of childbearing age, option D. Okay, so I'm going to give a few more seconds and then we'll end the poll and we'll see what our distinguished audience think the answers are. I hope all our panelists have voted.
Oh.
We're not allowed to vote. It
Oh,
says
really? Okay.
Hosts and panelists cannot vote.
Okay, so they've left us out of it, which I think is a good thing. So we can, because we have a bit more knowledge of what the answers are. Can we have the answers to the polls? Afolabi, for some reason, it disappeared on the screen. Can we have that again? Okay, I think I have it back. So we're ending the poll. So from our panelists or from our audience, apologies, the leading cause of maternal death worldwide is option number 3, postpartum. Can you see the results for the poll? Number 1, okay, good. The leading cause of maternal death worldwide is postpartum hemorrhage. 74% of our audience agree with that. We have 16% on unsafe abortion and 10% on high blood pressure. So worldwide, number 1 is PPH, postpartum hemorrhage. Number 2 is high blood pressure and related conditions. And number 3 is unsafe abortion. So the second question, the biggest challenge associated with maternal and child health services in Nigeria. The greatest number of our respondents said poor health infrastructure, that's 55%. The next greatest one is financial challenges, 19%. So that's debatable, but I think the poor health infrastructure or poor health services, not just the infrastructure, should be a better answer. And the last question, what is the most critical step required to improve maternal and child health services in Nigeria? So the highest number of votes go to increase the knowledge level amongst women of childbearing age. That's 45%. And 32% said more financial investments in healthcare. Thank you so much for that. So that would help to guide some of the discussions that we have later today. Thank you. I think we can, if everybody's seen the results, we can end that and move on to the next agenda. So I'm going to start the questions with Dr. Baloni. I know that in Kaduna State, you have a master plan, which you described to me in the past. And I do admire that. And I think it's a great idea, which a lot of people can learn from. So my question to you is, obviously, people that have various maternal and newborn child health programs are said to work in silos. So how can a framework similar to what you have in Kaduna State, which has been quite successful, for more effective collaboration be developed where every player feels the need to strengthen this interconnectivity towards better efficiencies. That way we avoid duplications. So speaking from your experience in Kaduna State, can you throw a bit of light on that?
Thank you very much for that question. I think one of the most important things about having different players in the field of maternal health is how effective your coordination is. And I think you mentioned that in the opening. If everything is not coordinated, you find people are just working at different levels. They're working at cross purposes. There's a lot of duplication and wastage of resources. So our experience in Kaduna is that we tried to work with the state strategic plan and through the annual operational plans. And so we derived our own state priorities and goals from sort of like from the strategic document, yes, but also from a bottom-up approach. Where we engage the service providers actually at PHC level around maternal health and ask them what were the challenges, what were the things that were stopping them from achieving the set goals that we had there. And once we identified that, we collated it and developed it around our strategic priorities. And this was done by everyone. So everybody that works in the health space in Kaduna has to be part of the development of that annual operational plan. And whatever we don't have in that plan, we try very hard not to implement unless it's an emergency, which we now have to adjust to. So that's one of the most important things, making sure that coordination is strong. The other thing is actually knowing what all the partners are doing. So mapping of the partner space and the areas of interest, and making sure that we coordinate them in such a way that people are not duplicating. So, for example, everybody wants to, 3-4 people want to work in family planning. What are our challenges in family planning and child spacing? And we now engage our partners around those challenges and say, okay, what support can you provide in this area and how do we do that? The other thing is making sure that we actually are all working for the common goal. And I know with a lot of partners that maybe private sector or not even private sector, maybe international NGOs, they all have their deliverables. And they sort of, it's always a struggle trying to get, those aligned with what the state really wants to do. And that's very key if you're going to stop verticalization and wastage of resources. So what we have is a very strong plan around our own priorities, jointly developed by all the players in that sector, and jointly implemented and jointly monitored. And very much, very important is integration of services. I know people like to show, especially if they're being funded. They like to show this is what the attribution to what their own support is. But what we've tried to do now is to make sure that we have this is joint and this is a common goal and this is what the impact is expected to be. And we think that it's not perfect, but we've seen in the last couple of years that people have actually come around to it. Initially, there was a lot of resistance. But when we stood firm to, okay, you don't have it, you didn't think about it in the beginning of the year, then why is it now a priority? Because you've changed maybe funding source or changed priorities to make sure that the focus is really on what the citizens of the state need rather than what everybody else needs. So these are some of the things that we've tried to do in our experience in Kaduna State.
I agree with you that the bottom-up approach, coordinating all the stakeholders, and mapping the interest areas of the partners would help to avoid duplication and wastage of resources. I love the point that you made, which I think is a key takeaway of joint implementation and joint monitoring and ensuring that they do what the citizens of the state actually need rather than what the funding agency or whatever needs. So thank you for that. I must congratulate you on the progress made in Kaduna State. I do think we need to celebrate ourselves when we do make strides. So congratulations to you and the entire health team in Kaduna State. They're indicators that show that you've done quite a lot. So the next question is to Iyadunni. So what role can technology play? I know that MSD for mothers looks at technology and they tend to lean towards technological solutions for some of these problems. What role can technology play, and how can innovative partnerships leverage technology and digital health solutions to improve maternal health outcomes, particularly in remote and underserved areas of Nigeria? You know, sometimes in those areas, internet coverage, broadband is a figment of the imagination rather than a reality. You know, so what can actually be done in such areas? Thank you.
Thank you, Tinu, for that question. A digital approach and technology is one of our underpinning guiding principles. So it's fab that you asked that question. And honestly, even this call, Tinu, if you know how we pray that we have a good connection, and I'm in Lagos, so that we don't lose connectivity while we're having this call. So we have real challenges when it comes to internet or digital, and we can't go away from that. We also recognize that digital access it could be proxy for, it could be a social indicator. I think it is a social indicator. And so many people do not have access to the internet, but this is what we know. We know that increasingly people are leveraging technology, and increasingly we're approximating towards more technology. And if we can get more people on technology, then we free up resources so that the people who do not have access to technology, or the people who need a physical brick and mortar interventions, have access to them. We can't throw away the bathwater with the baby. And so our challenge to a lot of our implementing collaborators is, how do we leverage technology? Because the question that you asked, how does technology help to support in remote areas? Let's start from the assumption that other people using technologies frees up resources for the remote areas that actually need in person because they don't have access. But if we look at the supply side, if we look at the provider side, it could help with, I think of it in three streams: data for quality, health, provider support and training, and financing. Healthcare financing. So when I talk about data for quality, I'm really speaking to the use of technological solutions for things like patient triaging. There are some, and sorry, before I go there, I think it's necessary to mention, because our president tweeted about this, that Starlink internet access, is now in Nigeria, and potentially can increase penetration to 100%. Of course, there are a lot of things that we need to sort through, but that is great news, because it means that if we can make critical investments in health facilities, we're not even saying the patients who don't have mobile phones or whatever, we're saying those facilities, you can make critical investments. There are things that we can do around data for quality. So data around helping to triage patients, healthcare records of the system, real-time tracking of medical supplies. So people like Uzoma can know when this facility is low in supply, and you can get that information real-time on a dashboard. These are some of the ways that it can be used. There support tools like the Safe Delivery app, like iDeliver. iDeliver is a tool that my organization has supported in Kenya, and iDeliver helps healthcare providers by asking critical questions and feeding that information into a system. They're able to very quickly triage patients. So you don't just have a whole large room of pregnant women waiting to see. You're able to tell who is a red light, who is an orange light, and who is a green light. And that can save lives. That actually does save lives. The Safe Delivery app is, for human resource. There are many times the woman, the healthcare provider, the person who is delivering the baby needs a reminder or needs some prompts on how to deliver care. The Safe Delivery app, you can download it when you have internet, and it works when you don't have internet.
Offline.
And a lot of offline,
Yes.
a lot of healthcare workers use it in Nigeria, in India, in Kenya. I have actually, I'm not a doctor, but I thought that if I ever am on a plane and somebody needs to deliver a baby, all I need to do is whack out my phone and put on Safe Delivery app, because it actually is quite simple. And, it makes everything, you need to do this. You should check it out. That's one way that it can help. During COVID, we saw a lot of the healthcare providers, for one of the projects that we supported, people that, hitherto, that's one of the good things we got out of COVID, the fact that technology can actually work.
Yes.
When we're pushed against the wall, when we don't have options, yes, we will leverage technology. There were sessions where we had healthcare providers, a lot of our Nigerian doctors who are leaving by the dozen on a daily basis. A lot of them who are working outside the country want to give back. And so the facilitators of the program, MDoc and Jupaigo, were able to create this echo sessions where they bring in healthcare providers in public sector, in private sector, and they say, okay, how do you manage COVID in a pregnant woman? How do you manage high blood pressure? They initially generated some topics, but guess what? By the time they were moving along, the healthcare providers themselves are telling you, this is what we want to learn. This is what we want to hear about. They bring a case study, the healthcare professional, many of them working, we had some people working thick in New York at the height of COVID, where the pandemic was the worst. They were able to bring the most recent approaches on dealing with these things to healthcare providers in remote areas in Lagos, in Abuja, which we would not have been able to do. And then health financing. One of the things that technology can help us to achieve is transparency in how funds are administered. And, there are different technologies. There's something that we're supporting the Farm Access Foundation to do. And it's really creating transparency between the payer, assuming that the woman is not the payer, the woman who is receiving care, and the healthcare provider are all aligned on the woman's pregnancy journey. You release funding, payment to the healthcare provider if he hits certain milestones. You're also able to track the women's journey and understand better why they're dropping out of the, after ANC. These many people come for ANC, but end up not having delivery.
Not having their delivery.
Transparency, you're able to see better and you're able to plan better with that information. I think the greatest thing for me, though, is the data. You are able to collect data that you can analyze. NPDSR, Lagos State has done an excellent job with that in terms of publishing their reports for the past couple of years. They have this annual NPDSR reports that tells us why women in Lagos State are dying. Can you imagine if we are able to take that across all private sector facilities, not just private sector facilities, local, community-based, then we can truly understand what the issues are and we can address them. If we keep medical
I
records,
knew you were the right person to ask the technology question.
No, I mean, I'm excited about the potential for technology. I'm not blind. We're not blind to the challenges, but the point is, this is an opportunity for private sector to support. This is where private sector can be innovative. This is where they can bring their expertise, their innovation. And it would be great to see more leaning in to technology, because I think that with the challenges that we're having with human resource,
human resources for health.
We don't even have a choice. I think we're beginning to see that clearly.
Thank you so much. I knew you would give us a very comprehensive response to that question. And I think the takeaways for me are the focus on data for quality, training for providers and our human resource of health, because we must be honest, even with task shifting, the people that are left on ground still need to be trained, and technology is the way to bridge that. And also healthcare financing, introducing transparency and making it more sustainable in the long run. So we look forward to the full implementation of I Deliver in Nigeria, similar to what you've seen in Kenya and India, because really, as our president has tweeted, we now have 100% broadband access across Nigeria. And so we must make it work. Thank you so much. To the audience, we would entertain a few questions. So if you have a question for any of our distinguished panelists, please put the question in the Q&A section, and we'll get to that shortly. I'm going over to Dr. Idris now. Speaking from some of the foundations that you laid in Lagos State, which are still yielding benefits years after, as mentioned by Iyadunni, can you help us to tell us how partnerships for maternal health can be evaluated to ensure that their impact is achieved, and then identify areas for improvement, areas that did not work out as planned, and still ensure accountability and transparency? Over to you, Dr. Idris.
That's a tough one, but I think the evaluation process has to start from when the program started. It's part of the program plan. We're planning to collect data, and the data we're going to use to analyze the benefits of how far we've gone, and areas that we feel were not performing well, to have a review of those things. That's one. Two, of course, using this data, that we're using the technology to collect some of this data. Part of that is training people on M&E, monitoring and evaluation, what to look for in terms of indicators that we establish for ourselves when we're doing that. So in planning, again, in programming, you have to set up indicators for the program. And you have to train people how to measure those indicators using the data available. And using data available and implementing the thing. Then the other thing has to be dissemination. If you are collecting data, you're holding regular meetings with the various stakeholders and giving them information as how far we're going, the areas of performance, areas of less performance. That way you can let them know precisely which areas to address. And more importantly, again, reporting, just like the last speaker said, we created documents that we were disseminated to various people, different stakeholders, just to appraise them of how far we've gone and what they need to do. The last bit, again, has to do with the policy makers themselves. It's one thing getting some of these results, is another thing, again, getting government to back up the processes you're implementing. So we need regular feedback to the people at the top, informing them of what the situation is at the grassroots. And getting is a bit, I think evaluation basically is data-based in our environment. And again, we need to get more people involved in database again. We established what we call the dashboard, where we're measuring the various activities, which areas we were doing very well, which areas we're not doing very well, why we are doing that, why we're not doing well. And take, for instance, the maternal death review. We started with a facility before, Lagos Island Maternity, and now we now spread it to some of the other facilities. And of course, in doing that, again, we're training everybody involved again, what to do, what not to do. And of course, the idea was supposed to be no blame, no gain, or something like that. You don't blame anybody. You just wanted to find out what are the major causes of maternal morbidity. I got people again to train the various staff again, to address the areas of deficiency. But basically, I think evaluation, evaluation has to do with database, tracking data using information technology, and of course, training people and enlightening the public. More importantly, again, like somebody said earlier, we needed to involve the community. The community that must be involved in the monitoring and evaluation processes. That's the only way we can ensure sustainability. I think I'll just stop here.
Thank you so much, sir, for that answer. I'll start from the end, getting the community to take ownership of whatever program has been put in place, and ensuring that right at the beginning of the start of a program, the evaluation process is already planned in. It shouldn't be after the fact. And then importantly, collecting, analyzing the data, and then disseminating the results and the information. Like Iyadunni mentioned earlier, Lagos State publishes some annual reports which are available to everyone. And then having some type of dashboard where that can be tracked and changes or recommendations implemented once you see the data, the direction it's pointing at. I like the concept that you said of no blame, because when you have no blame, then people are encouraged to actually record accurate data rather than doctoring the data because they assume that they'll be sanctioned. So I'd like to close with what you said, that there should be a good feedback mechanism for people at the top, of which you are one of them, sir, so that that feedback mechanism and the lessons learned can be implemented by policymakers in the system. Apologies, Uzoma, I missed when your hand was up. We have a question for you, but I'd just give you an opportunity first to speak to that. I saw your hand up.
Okay, I think that was when Iyadunni was speaking and talking about technology and telemedicine, specifically. And I was going to make a comment about looking at things across the entire value chain. For instance, we had done some pilots with telemedicine organizations set up by Nigerian doctors in the diaspora during COVID. And a big issue they had was fulfillment. I see a patient, I make a diagnosis, time to get medication, people aren't moving around. How does that happen? So integrating those who are in the distribution, business as well is really important, because we were able to, connect with pharmacies in certain areas, and that's the only thing that limited the scope. How many pharmacies with delivery services could we activate, at that time? But it allowed us to aggregate the demand and then use, the channels that were moving in already to ensure that the patients received what they needed. So I'm saying, don't leave us out of the conversation.
Thank you for that. So our question for you is, how can partnerships for maternal health be integrated into broader health systems? I mean, we've gone beyond the point of just supply chains. We're looking at the entire value chain in the healthcare system. So how can we strengthen some of these efforts, and what are the potential benefits of such integration?
Okay, I think ideation is where it would begin. I think we have a PPP, a national PPP policy on how public-private partnerships should be executed. I'm only aware of the much older document, the early 2000s, circa 2005. So even beginning, with something like that is really, I think, key. A lot of effort and thinking would have gone into articulating how the various, partners can come to the table and integrate. There isn't enough communication. Even if I look at the NGO space within the pharmaceutical end of things, where there's perhaps a focus on maternal health. So somebody decides these are the indices we want to work on. Let's just say malaria. You might find that one end of the same NGO is working on ensuring supply. So they're getting their scorecard checked, along those metrics. Then another end has a lot invested in building local manufacturing capacity, but you'll see there's no handshake. So somebody gets an A star if I ensure that, the current channel, which is importation, is running on track. And then somebody else's scorecard should intersect with that. Because if the long-term goal is to ensure availability of products, if that's what is identified as a cause, then you can't pass if I'm failing. And sometimes you see that the overall scorecards are so fragmented. There isn't that relay. Who watches 4x100 and just celebrates one leg? We're talking about which team won, because there's a clear goal. So I think that there should be more collaboration and an interdependence on the success of whoever's got next, because people are getting a lot of funding for incomplete work, if they would forgive the use of that descriptor. It looks fabulous over here, but at the end of the day, what was required didn't get to where it was actually needed. So I think the measures have to run across the entire value chain, then people are much more likely to, develop policies that are more fair to delivering on the objective. So that also comes back to being at the table when the discussions are being held. For instance, I love what Kaduna State is doing, where we've had direct interactions, and there was a handshake between local manufacturers and a number of states, because there are an assortment of issues. They have drug revolving funds, and forgive me if I stay in the drug area, but at least I can give you very practical examples. One of the issues is PHCs or whichever centers not having the drugs when the mothers come. So although there is a provision, in the structure or the ideation for it, whoever is ensuring supply, is dropping the ball to some degree. So I think one of the things they looked at is, well, how are supplies being funded? Perhaps they can revive these DRFs, so drug revolving funds. So USAID gave support with looking at the logistics of supply. And in some instances, there was seed funding. So states could procure certain products and then, maybe supporting with the pricing structure, negotiating with manufacturers to lower those costs, to ensure that, okay, we've identified mums are coming, drugs aren't available. Now drugs are available and there's a revolving system. But that had to go outside of the state, system and enter into the private sector. So things like that end-to-end integration.
I agree. Thank you so much. I agree with you that there's some degree of fragmentation and there should be a handshake across various stakeholders. I love the analogy of relay race, where you have 4 people in a race. Success is not achieved until you get to the actual end of the race. The national PPP policy, I do believe we need to look at various models of PPPs. Not just one size fits all, because there are various considerations that come in at different parts of the health sector. And I do like the idea of ideation, innovation. PSHAN used to be at the forefront of that with our National Health Innovation Marketplace, where we had people in the private sector just come up with ideas and make a pitch to see if they could scale that and get funding. So that innovation ideation is still the way to go. Thank you so much for that. So we have a few questions in the Q&A section, which I'm going to check and relay to our panelists. Some of the questions are specific, some are a bit more general. Okay, let me start with the question to for some reason, it appears that Uzoma has a number of questions. I actually wanted to give her a break before going to her again. So I'm going to jump some of your questions so you have a bit of time. Okay, so Iyadunni, we have a question on how can we improve public-private partnerships to ensure the sustainability of maternal health-based projects across communities. Did you get that question?
Yes, I did. Thanks, Chinua.
Okay.
I think this is a question for the both sides of the table, so I can speak on the private sector. I think MNCH is a collective responsibility. We need, like I said, the whole of government and the whole of society, and people typically think of the whole of society as private sector. We have data that shows that more than 50% of health services are provided in the private sector, and very often at high cost and poor quality. We know that we need to integrate private and public, but we want to integrate quality. And so I think it's important to bring private sector to the table. In a lot of conversations that I had, private sector is very absent. And I think that is any meeting I come into. Are you hearing from private sector? Yes, private sector can do a better job of getting organized, but we do have some private sector representatives. The health, I think it's called HERFON or something. The health. Forgive me, I can't even remember the name of the platform, HERFON, that
Foundation of Nigeria.
Yeah, that's the one. We have the AGPMP, we have the the nurses, the nurse practitioners body. These are opportunities to bring them to the table. When we think about private sector and PPP in health, we think about health facilities, but it's so much more than health facilities. It is pharmaceutical companies, it is distribution and logistic companies, it is tech companies. Private sector comes in for every problem that you have. I guarantee you, there are many shades of private sector that can fit that. That can solve that problem. It's bringing them to the table. We're not saying that you accept private sector like that. We want the government to take that leadership role in setting the direction centrally and letting the private sector come to the table and say, these are where the challenges are. This is where we need to see innovation. We need a solution for this. And if it can be solved sustainably, if it can be solved in a way that can continue, you can get the private sector to fill that gap. So I think number one is bringing them to the table and recognizing that there is a need to define quality standards when you're dealing with the private sector. Don't be anxious to, I think you should be open to innovation, I think is the word that I'm trying to say, is what I'm trying to get across. We've been doing it the same way. We've gotten these sorts of results. Can we try on a small scale and see what the evidence is? I think push them to provide the evidence to support the work that they're doing. We have worked with private sector organizations on the technology side in health facilities. And many of them, if you are supportive of them, are able to deliver and provide the evidence that can support. We have fragmented examples. What we want to see is how do we take these examples and scale them? And so I think it's just bringing them to the table, being open and recognizing that innovation, you won't get it right at the first attempt. You approximate to success, gradually approximate to success. There are signs and telltale signs, telltale indicators that will let you know that you're on the right path. But be patient and bring them to the table.
Thank you so much for that. We have quite a few questions. I'm not sure what's going on, Uzoma. You have so many questions for you, but we're going to just give you a little bit of a breather and go back to Dr. Idris. And then I'm going to give the last question to Uzoma and Dr. Baloni, because they're two sides of the same question. But starting with you, Dr. Idris, please. Historically, measures to improve women's health have focused on antenatal, pregnancy, and more recently, gender-based violence, combating that in the society. What other areas of maternal health do you think are underexplored and that we could focus on to improve women's health? Over to you, sir.
Yeah. First one I would think of is blood transfusion. Well, we do realize that one of the major causes of maternal mortality is hemorrhage. I'm going to relate to what we did in Lagos State too. We tried to privatize, we tried to introduce a private-public partnership in blood transfusion in Lagos State. That's because one, we realized we didn't have the capacity. So we got some private sector people to screen the blood, whatever blood available in the state before anybody could use that. And from there too, they did some kind of partitioning at the blood products, creating blood products. This is historically to be able to address some of these hemorrhage issues of hemorrhage. So the blood transfusion service was reorganized. We had a central unit at the Lagos Island maternity there. We involved the private sector in blood screening. We also have screening centers in different hospitals. And that way, again, we could monitor the amount of blood being produced. I also do know that right now, that system needs to be expanded fully because the demands far outweigh the supplies. The second one, if you look at the other delays in the 3 delays, has to be transportation or access of people to health services. And in this case, again, we involve the ambulance services in the state. And more importantly, again, for the riverine areas, again, we had the river ambulances, or we engage the Kano providers with the help of some of these donor agencies to help us address this ambulance service to the rural areas with respect to maternal and child health services. Yeah. The last one, again, has to do with referral system. And that's starting from the primary healthcare system, the secondary facilities and tertiary facilities. And one of the major things we did again was to strengthen primary healthcare systems, build facilities, staff them, so that at least the staff there could be able to address some basic issues, and where they could not handle, again, the refer. And this referral system, again, was based on, again, the issue of protocols, designing protocols for use in the various facilities. And this wise, again, we engage the service of some partners. Sogon is one of them in training our staff. The other has to do with logistics supplies, and the pharmaceutical industries were helpful in this. So, like I did say again, the blood banking system to address the issue of hemorrhage, training and advocacy to improve knowledge base of our people, again, going to the community, again, using different facilities, different partners to provide knowledge base. And the last bit, again, has to be mental health. This is one area where people tend to forget about our services. It's a huge problem here because postpartum, what do you call it, depression?
Depression is real.
Yeah, it is.
Unfortunately, we don't have enough human resources to address this. And this is where, again, where education on public advocacy is essential. Whilst governments at various levels, again, are recruiting more and more psychiatrists and building more and more psychotherapists to be able to address this. So blood banking services, ambulance services, mental health issues and referral system are key areas, again, we could address. Somebody mentioned infrastructure, and I just give an example of what we did in Lagos State again. We created in some local government what we call maternal and child health services. That's in context of comprehensive of care. Within each facility, again, you had the maternal service, you have a childhood service and neonatal services. And in combination, again, training, developing capacity in all those emergency obstetric care, life-saving skills using private sector, using a partnership with various groups to address some of these. These are areas, again, we explored in my time, and I think they're still doing similar things here. And of course, using the academia to conduct research. It's a continuous process. Thank you. Thank
you so much, sir. Yes. So areas that, in addition to regular delivery and antenatal services, blood screening, blood transfusions, working with the private sector to get that in place. Even the maternal health care centers, MCH. I know Lagos State has one in Ajah, Ekpe, and a few other places where they have very dense populations, and they've made a huge impact. They have a lot of PPPs in place at those centers as well. I was lucky to work in one of those. Looking at the area of transportation, referral system, very important, and then mental health. Unfortunately, in Nigeria, even for regular people who are not pregnant, we don't have enough human resources for health to attend to the mental health issues in Nigeria. So the public advocacy, where we teach the public how to recognize the signs, and quickly take some steps when we have that, very important. And of course, the academia. Nigeria academia, one of the best academia in the world. Unfortunately, so many challenges with the Nigerian health educational system, which hopefully we can overcome. So thank you for that. So the last question I have is a two-part question. There's a question from Lola Alonge of the Chai Initiative. I'm sure you can see that. she says, what is Emzor doing about global shift from iron and folic acid for pregnant women to multiple micronutrient supplements? And how can the government create an enabling environment for this to happen in Nigeria? But before we go to your question, I would like Dr. Baloni to speak about postpartum hemorrhage in real terms, because it's such a major cause of death worldwide, and particularly in Nigeria. So you'd be surprised that it could be from this particular session that people will have some idea of what to expect, what to do, and what to look out for. I know it's been a while since you've been in clinical practice, but I would like you to tell us how does this play out, the PPH, in the clinical setting, so that it gives more of an idea. Like Iyadunni mentioned earlier, what if you have someone on the plane who's going into labor and you don't have data? Maybe you're one of those planes that doesn't have data for you to bring up the iDeliver app. What would you do? So over to you, man. Then we'll end up with Uzoma on her question.
Thank you for that question. I think what we've found in Kaduna State that is in keeping with what the global picture is. And one of the top three is postpartum hemorrhage. The other is sepsis and puerperal sepsis, and the other one is anemia. So we have those three as our top causes of maternal morbidity and mortality, especially around deliveries. And this has borne out with the community MPDSR program that we have. We have anecdotally, we sit down with the community and find out where we have maternal deaths, what were the causes of deaths, and most of the time it's bleeding. So what have we tried to do as a state? We have a state newborn action plan, which also has a component about the delivery. So although it's targeted really at neonates, you have to look at the causes of things around perinatal and peripuberal causes. And one of the new partnerships we have, which is innovative and which is the first of its kind in Nigeria, is that with Zipline, where you have drone delivery of commodities. And that we have tried to leverage to use for delivery of blood and blood products at areas where you have hard to reach or far to reach areas. We have security compromised areas, and we have rural areas where most of these women that die of postpartum hemorrhage are actually in those places. Although this hasn't been long, we haven't evaluated this. This is just coming to about 6 months when we started the Zipline. I'm sure that there will be an impact in the delivery of those. We've also built capacity of the health workers. So you mentioned about human resource constraints, and we have no insufficient skilled birth attendants. So what we've tried to do there is to look at community health extension workers, which senior ones, which we give added training on MLSS, modified life-saving skills. And also we've augmented that with recruitment of midwives to all those areas. So first of all, you have to have people with the skills to be able to provide that care. And then you have to give them what they need to action on it. So the blood and blood products in line, and as well as the capacity building. It's something that we haven't quite evaluated, but anecdotally, we can say that we're seeing a change. The other thing, of course, is to make sure that pregnancies are supervised, because it's from there that you have an inkling on who is going to have those problems. The other program that we're also stepping up is postnatal visits. Postnatal visits to women. Sometimes this hemorrhage doesn't happen at delivery, but postpartum, maybe in the first week. And that usually is connected with sepsis as well. So these are some of the things that we're trying to do to address postpartum hemorrhage, which is a major problem. Thank you.
Thank you so much for that. The partnership with Zipline, yes, we've heard about that. I know they're looking at some contiguous states in the vicinity of Kaduna to also implement that. And we look forward to when you eventually do evaluate your data on the impact that that has made, and commendable actions on the capacity building with the modified life-saving skills, which could really be what would make the difference to a lot of women who have the bleed post-delivery and even at the delivery bed. We have an additional question for Uzoma concerning manufacture of family planning commodities. And I also wanted you to speak to uterotonic agents manufactured in Nigeria, which you mentioned briefly. So over to you. In addition to your earlier questions, you have quite a lot to answer. Over to you. Thank you.
We'll make it as succinct as possible. So perhaps I'll start with the question from Salonga Chai. Chai, we're here for you. I can't put it any more clearly. You know, Chai has done some wonderful work in country. Years ago, when the WHO numbers came out again, I think was updated numbers, Nigeria was recording horribly around diarrhea. You know, we had a lot of infant mortality around diarrhea initiatives, and rather than, you know, kind of say, well, they don't have this or they don't have that, it was identified that they wanted to use oral rehydration salts, ORS, and zinc. At that time, I don't think anybody was manufacturing that in Nigeria, but they weren't put off by that. So they engaged manufacturers as well as the wholesalers. On Emzor's part, it meant we had to invest in plants and machinery because we didn't make dispersible formulations, and we weren't making dry powders. Well, we did have a dry powder line, but exclusively for antibiotics, which you can't mix. So I think it's the same thing for micronutrient powder engagement. But I can happily tell you, we started supplying we did our first supply of micronutrient powder over 10 years ago. It was on a contract manufacturing basis, but then we subsequently registered, you know, a couple of formulations as a 5-component and a 15-component, and just parked the registrations, waiting until, you know, there was interest or a buyer. And that began with an NGO that's active in the nutritional space. So we've been making supplies for a couple of years, and the intensity this year in terms of interest and just the, you know, the supplies going out has been consistent. So micronutrient formulations are being made here, but most of the programs we see are directed towards children rather than pregnant women. But if an adjustment in the formulation is required, then we'd be happy to engage so we can get the necessary formulation development completed and registration. So, but again, I'll just highlight the earliest success was because of the communication. They did a great job of pulling everybody together, you know, as opposed to what often happens, which is a report goes out saying there's nothing here, nobody does this, you know. So give us a chance. Like the Nigerian manufacturing sector is increasingly responsive, and I know Emzor certainly is. Still on products. Family planning. Yes.
We put you on the spot.
Yes. Well, that's because it's a very serious topic, because it's right. It has its back leaning up against the back of abortion care. That's a very difficult conversation in any country, as we're seeing, but it's a very touchy one to have here. So I would say that because of the understanding, you know, we've talked about birth spacing, because of the amongst particularly the professional community about the impact of issues like child spacing, mental health, and so many other things. It's a conversation that we have to have, but it has to be broad. You need to involve the faith-based community as well. This is not the West. You know, even in the West, we can see, you know, the reverberations
that it causes.
Yes. So
yes.
Ours will be of a different flavor. We need to understand and not approach it naively. But the other aspect as well is competence for local manufacturers, because these are micro doses. To put it in perspective, probably 1,000th of the dosing that might be in a traditional, medicine that a manufacturer would be making, locally, less than 1,000th of the dose that's contained in a paracetamol tablet, for instance. So there are technical competencies that you have to onboard, otherwise you get disastrous results. A 10% error gives you a much more serious consequence. So the good thing though, and I'll just bring in Uterotonics as well, is because you're in the hormone space, hormones are dosed at very low levels. So when we were embarking on introducing misoprostol, we knew that we had to do it via tech transfer agreement. It's great to do your formulation development and your research and development, but there was too much at stake. We just knew we couldn't afford to fail at this. So it's going to be the same system. Fortunately, there's increasing openness to tech transfer within the pharmaceutical space. So I have no doubt that it can be delivered upon. And then also on our own, in the few years that we've been manufacturing Eprostol, that's a misoprostol, we've gained experience in managing these microdoses and all the implications, laboratory testing, et cetera, and even separating that. So that information is coming on. And for the injectable, I know that Duhel was able to successfully deliver oxytocin. And that has its challenges because it's a cold chain storage product. So we also need to look at distribution, warehousing, storage across all our facilities as well. So I think it's something that we have to look at Emzor's, and we've had internal discussions around that, but it's not a product you just jump in and start to manufacture. Predominantly, I think the majority of the quantities in country are coming through the NGO channel. So we need to speak with them. We need to, as I said, talk to faith-based, engage the communities and understand where the issues are going to arise so that you come into that space informed and allaying fears, allaying assumptions, and being very factual and very competent about delivering on those.
Thank you so much for that response. And Dr. Baloni has just brought to my attention that in Kaduna State, they have a program at the community level where misoprostol is provided to women with postpartum hemorrhage, and it has been very successful. So that's great news, and we hope that other states can follow in those footsteps. So I'd like to thank my panelists so much, and I'm going to go around and give you 30 seconds each with your key takeaways, which you'd like any member of the audience to leave here knowing. So we're going to just 30 seconds, start from the reverse this time, and start with Iyadunni, back to Uzor, then Dr. Idris, and close with Dr. Baloni. So what is your key takeaway, your burning thing you need to get out there? 30 seconds. Over to you, Iyadunni.
Thank you, Tinu, and thank you for making me go first. Nigeria's health system of the future is one that is centered on patients, women and children, and their needs, their experiences. It's one that engages communities to ensure that whatever is implemented, whatever solutions we're bringing fully reflects what the community needs, and so that the community can take ownership from them to ensure that the schemes that are implemented are driven from national, but have local buy-in. And this is the key to sustainable improvements in maternal health care. This is what we want to see. This is what we support. And this is what we're asking you to come along with us, because it's a whole of society, whole of government approach. We all need to be on board. Maternal health is everybody's business. Thank you.
Thank you so much. Over to you, Uzor. What's your key takeaway, your burning topic that you'd like to close the session with?
I'll pick up the baton from Iyadunni. It's everybody's business because it's a double impact business. You cannot have maternal discussions without child. So they're right there. It's a package deal, massive impact. The good news is things are changing rather rapidly, and I'm really excited to see that we are becoming more and more a part of solving our own problems. There are some unique aspects to why our numbers are as high here, and nobody's better placed than the various organizations. So the takeaway is we come together. We really need more forums like this. We need to look at, and let's look at the existing policies. It's very difficult or lengthy to change anything at the government level when it comes to articulated policy. So let's dig out what's good there, assign responsibilities and check in regularly to make sure we're delivering on that. It's so worth it.
Fantastic. Thank you. Over to you, sir, Dr. Idris.
Well, I align with the past two speakers, but more importantly,
this is a relay race. We're all in alignment. Iyadunni started off. Uzoma is continuing. Now the baton is with you, sir.
Yeah, rather than repeat it again, I believe we know all the problems in our country, especially with respect to maternal mortality reduction. But I believe one key aspect is leadership and governance. If you can get the leadership right at the various levels of government, we can make an impact on this. Lastly, as a governance issue, I know that somebody raised a question on legislation. And I must need to say again here that abortion, unsafe abortion in this country is a major contributor of maternal mortality. I know that legislations are being proposed for abortion. We also understand the problems we have in our country here, but it's something that is worth looking into. And again, it requires educating the public, it requires educating the policymakers, it requires, again, the involvement of every other person here. Like everybody says, health is everybody's business. Thank you.
Thank you so much, sir. And over to the Honorable Commissioner, Dr. Baloni, for your burning takeaway.
Thank you very much. And like everyone else, maternal mortality and morbidity is everyone's business. I think we need to improve on coordination, which is key. We need to have a shared vision and agree that we all want to make this space better. And align with priorities of the state and actually of the people. What are their issues and how we can help, the people that actually need the service. Innovation and partnerships are key. And this forum is something that we should really explore and push the boundaries on how we've been working with the private sector to the betterment of the women and children in Nigeria. Thank you.
Thank you so much. And so I'm going to give the last leg of the relay race by summarizing what you've all said. Maternal health is everyone's business. We need a whole of society approach. Leadership at the various levels of government is key. On safe abortions, we need to make some impact there, and we need to all work with a shared vision and align our priorities to better the people that we're actually here to serve. Thank you so much. I hand over to my colleague, Mr. Afolabi Ayela, who would give the closing remarks on behalf of PSHAN. Thank you. Okay, it appears the internet has cooperated with us all through. Maybe it's finally decided to act off. So on behalf of Afolabi, okay, you're back on.
Yeah, good afternoon, everyone. So I would like to take on the closing remarks by saying, dear distinguished panelists and attendees, as a representative of the Private Sector Health Alliance of Nigeria, I would like to extend my heartfelt gratitude to the esteemed panelists for their insightful contributions to our webinar. I would also like to express my appreciation to all the attendees who participated in this event and contributed to its success. The views, questions, and answers shared during the webinar have shed light on the challenges and opportunities associated with improving maternal health through innovative partnership in Nigeria. We are particularly pleased that this event was held during the month dedicated to celebrating women, and it has successfully highlighted the important issues surrounding maternal health. We recognize the success of this webinar would not have been possible without the active participation of all those who have joined us. Your engagement in the polls, discussions, and everything has been truly inspiring. And we hope that the knowledge gained from this webinar will inform your actions as you seek to make positive changes in your communities and beyond. Once again, thank you to our esteemed panelists, attendees, and everyone who made this webinar a success. We look forward to future collaborations that will enable us to continue our work towards improving maternal health in Nigeria. I would like to end by inviting everyone to visit our websites, PSHAN.org and adhfp.org, to learn about how you can contribute to the advancement of healthcare in Nigeria. Your support could make a significant impact on the lives of many individuals in need of quality health. And everybody can do something. Thank you for your time.
Thank you so much, everyone, and have a lovely day. Take care.
Thank you.
Thank
you for having us.
Yeah.
Thank you.
Thank you.
Thank you.